water here. This is the first time I've ever done this. My experience is 30 years in GYN oncology. I'm at the Stevenson Cancer Institute part-time. I actually retired in 2014, but they drug me back in. I'm doing part-time work there. My teaching experience is in the clinic. We usually have third-year medical students come for half a day in our clinic, and we have them interview patients. And, well, the doctors don't have time to mess with them, so they dump them on me. And so I'm going to talk to you guys about what I go over with them. Let's get some basics done. If I use terminology you're not familiar with, please speak up. Let's get an understanding of what makes a carcinoma as opposed to a sarcoma. Does anybody know the answer to that? Okay, so carcinomas are what tissue type? Epithelial. It's not epithelium. It's not a carcinoma. Sarcomas tend to be more of a connective tissue, like bone, adipose tissue, venous tissue, muscle. Do you know the difference when I talk about stage and I talk about grade? You know what I mean by stage and grade? Stage is I'm talking about how far along the tumor is. Grade is talking about what does it look like histologically? What does it look like under the microscope? We're going to come back to these slides, and I'm just going to go through some stuff. I want to start with cervical disease. Does anybody know what causes cervix cancer? HPV. Any HPV?
Certain strains.
16, 18, couple of the 30. High-risk HPV. There's almost 200 strains of HPV. At least 12 types have been designated as carcinogenic. Another 8 types are possibly and probably carcinogenic. What is the precancerous lesion for cervix? That's a late precancerous lesion.
Dysplasia.
I'm sorry?
Dysplasia.
Dysplasia. What's another term for cervical dysplasia? Does everybody know what dysplasia means?
Changing of the tissue.
The way I think about it is plasia is growth. That's not quite what we want to see, so dysplasia. The other term is CIN. Cervical intraepithelial neoplasia. All right. So you may, and those terms are interchangeable. So I can have varying degrees of dysplasia. I can have mild, moderate, or severe dysplasia, which is equivalent to CIN1, CIN2, CIN3. Some people call severe dysplasia CIN3 carcinoma in situ, or CIS. I'm not a big fan of that term, and the reason I'm not is I've asked some patients before, have you ever had a cancer? And they go, yeah, I had cervix cancer, and you look at your history and you go, well, that makes sense. You still got a uterus, you haven't had radiation. But somebody probably used the term carcinoma in situ, and what is the patient here? When you go, well, you got carcinoma in situ. So, oh my God, I've got cancer. Well, no, you don't. You're going to have cancer if I don't interrupt it, but carcinoma in situ, you guys are going to hear it. just understand that's still a pre-invasive lesion, okay? Not for long. It's full thickness. What has to be present to call this a cancer? It has to penetrate the basement membrane. It has to invade. By definition, does CIS invade? The answer is no. So just understand that CIS is pre-invasive. So we think of CIN, we think of normal, CIN1, CIN2, CIN3, invasion as a continuum. It takes many years to get from point A to point B. It can take as much as 30 years to go from normal to an invasive lesion. So HPV-16 is the most oncogenic form of HPV, and it accounts for probably over 50% of cervix cancers. If I'm going too fast, you guys just... I like the interaction, so jump in if you so desire. So 16 and 18 are the high risk, are two of the most risky HPVs. 18, about 10% of the cervix cancers are related to HPV strain 18, and it's associated oftentimes with adenocarcinogenesis. 31, 33, and 45, probably about 5% of cervix cancers. There's over 100,000 pre-invasive lesions diagnosed annually, so this is a significant problem. Most infections don't develop into a cancer. Most of them are cleared immunologically, so we see that we've got some changes on our screening, and a lot of times we'll just choose to watch them. For instance, CIN1, mild dysplasia, we don't tend to do much about that. We're going to watch that because oftentimes, or most of the time, the patient's going to clear those immunologically. What are the risk factors? Anybody have any idea what your risk factors for getting an HPV infection?
Multiple sexual partners.
That's one. That's a big one. Anybody else?
Unvaccinated.
That certainly would fall in there. So early onset of sexual activity is one, and there's a reason for that. I'm going to discuss that. Smoking can play a role. Tobacco carcinogens interact adversely with the high-risk HPV types, and they increase your risk. Also, smoking reduces your immuno-mediated clearance. The next one is immunocompromised. If you're immunocompromised, you can't fight the virus. So that's obvious why that's a problem. We already mentioned multiple sexual partners. Failure to be involved in a screening program is a risk factor. Who tends to fall in that? Lower socioeconomic groups tend to fall in that group. And just as an aside, I don't know how important this is, but by the way, the textbook I used is the Creasman Clinical Oncology, G1 Oncology. The slides that we're going to look at, it's got my name on them, but they're actually from Dr. Lisa Landrum, one of my friends and professor at the Stevens Cancer Institute. Let's see, oral contraceptives have been associated with some adenocarcinomas of the cervix. I want to back up here. Early onset of sexual activity. Why would that be an issue? Well, I think it's multifocal. I think that the earlier you get exposed to a high-risk HPV strain, the longer it has to do its damage. But it even, there's actually an anatomic reason. Does anybody know what the transformation zone or the squamous-columnar junction is? I'm sorry?
Is that the area that's right around the external eyes?
Uh-huh. Okay, what's going on there, do you know? What we have there is we have columnar epithelium undergoing metaplasia. You know what I mean by the term metaplasia? Metaplasia means that we have one cell type turning into a different cell type. So columnar epithelium, which tends to line the inside of the endocervical canal, butts up against the stratified squamous epithelium of the vagina. And so we have columnar epithelium undergoing metaplasia and turning into squamous epithelium. A lot of cellular change going on there. This is where most of your cancer starts, with the squamous columnar junction. When you are very young, the squamous columnar junction tends to be ectocervix, exposed to all kinds of insult. As we age, that squamous columnar junction tends to kind of migrate back up endocervically, and that in and of itself might give us a little bit of protection from the effects of the high-risk HPV. It might be less exposed. So I think there's multiple reasons why early onset of sexual activity, but the big one is the location of the squamous columnar junction. The median age of sexual debut in the U.S. is about 17, according to this textbook. Infections with HPV, at least high risk, and the subsequent cervix cancer probably could be eliminated. We have a vaccination. We actually have several vaccinations that cover these high-risk HPV strains. Unfortunately, in this country, we don't have a significant participation with that vaccination. But even with the small amount of participation, we're already seeing decreases in the incidence of high-risk HPV infections, dysplasia, and subsequent cervix cancers. The target age for prophylaxis or vaccination is going to be target age about 11 to 12. You can use them as early as 9. The thought is we want to get these vaccinations on board before folks become sexually active. The vaccinations are usually 3 injections over 6 months, and probably over 80% of patients or people who are sexually active have had an HPV infection. Most of us never even know it's subclinical. So it's not a small problem. It can be a huge problem. Let's talk about screening a little bit. Of course, with the advent of pap smears many years ago, that was a huge find, and we're trying to collect cells there at the transformation zone. We get overline the cervical component, and now we have Hpv testing. Pap smears. Most of the time you're going to see them used in what's known as the Bethesda classification, and that describes the accuracy of the specimen, and then it tells us whether it's normal, atypical, dysplasia, and so when you start looking at pap smears or path reports, you're going to see things like ASC, or that's atypical squamous cells. You might see something called ASCUS, ASCUS. That's atypical squamous cells of undetermined significance. You might get a pap back that says ASC-H. That's going to be atypical squamous cells can't rule out a high-grade lesion. You might see LSIL, which is low-grade squamous intraepithelial lesion. And then they also divide between squamous and adenotype dysplasias. Adeno meaning gland, so you might see atypical glandular cells. You see atypical glandular cells, or you even see glandular cells in a postmenopausal female. That's problematic. Most postmenopausal women we should not be seeing endometrial cells in our pap smears. Any questions so far? So we used to think that screening, we need to start screening these people as soon as they become sexually active. Well, what that did is we started finding a lot of abnormalities, and we started doing a lot of procedures on these young girls. And that's not without potential morbidity. You're whacking away at the cervix. What's something I can cause long term if I do too much removal of cervical tissue?
Infertility.
I'm sorry?
Infertility.
Yeah, why? It's not so much infertility, however, we can have some infertility from the scarring and so on, but it's what's even more concerned is cervical incontinence. The cervix job is to hold that pregnancy up there. Well, if I cut out a lot of that muscular tissue, that cervix may no longer be able to maintain a pregnancy. So we try to be as conservative as possible. So we decided maybe we ought to stop having these young girls because the data's showing us that most of these are going to regress. These lesions, you know, these CIN1s and CIN2s, most of them are going to regress on their own. Maybe we're doing more harm than good by going in there and chopping away and treating these things. So they changed the screening recommendations. Now we don't start screening until age 21. At age 21, it's recommended that you start getting pap smears every 3 years. When we hit age 30 to 64, you can continue to get pap smears every 3 years. Or for those who want to extend that interval, you can do every 5 years with co-test, meaning that not only we're going to do a pap, but we're also going to do high-risk HPV screening. You can stop screening at age 65 if the patient has had 3 negative PAPs or 2 negative co-tests, or you can stop papping after a hysterectomy for benign disease. How do we treat dysplasia? Well, that kind of depends on where it's at. Is it mild? We don't do much about mild or CIN1. We get to CIN2, okay, that looks like you're not going to clear this. We're probably going to have to interrupt it. One of the things we might do is called the LEAP procedure, or a LETS. LETS standing for Large Loop Excision of Transformation Zone. Anybody seen a LEAP? You've seen one?
Mm-hmm. We used to do them in the doctor's office I worked at.
Okay, all right. So a LEAP procedure. What we have here is we've got a, let me see if I got, we've got a wand here. It's got these little arms here, and there's a wire. This wire is hot. It's electrified. And we take that and we use that almost like an ice cream scooper and just go scoop out the upper layer of that cervix, trying to get that transformation zone. Sometimes we may act, and we can do these leaps in the office, as you pointed out. Sometimes we have to go ahead and take you to the OR and do a cone, what we call a cold knife cone biopsy. And that means we're actually going to take out a cylindrical cone-shaped piece of tissue. And So here's the cervix. So we're going to take out a cone-shaped piece of tissue. Cones are typically diagnostic. They can be therapeutic if we get negative margins, there's no evidence of invasion, then that's might be all that patient needs. For the leaps, again, they're sometimes our margins are hard to figure out if they're positive or negative because of the heat artifact. The cones there, we're going to get a good histologic specimen. Questions so far on that?
I have a question about the pap smear every 3 years. Are there still, first of all, when did the transition from yearly, before age 21, when did they make that change over to not suggesting it until 21?
I don't know that I can adequately answer that. It hasn't been that long, but it's been several years. There was
I think it was 2012,
Was it? Okay,
I think.
around about there.
the advent of that came after a big trial that Dr. Walker did at the Stevenson Cancer Institute. It's called ALTS trial, and they started looking at randomizing people. We're going to watch you, we're going to go ahead and do our standard of care, and we figured out that we might be doing more harm than good on these younger girls, because again, significant percentage of these patients will clear their disease, and so it was decided we need to stop looking at these young girls, and not that 21 isn't very young, but I mean, we were whacking away at 17, 18-year-old girls, and now we know that's probably not what we should be doing. Does that answer your question?
Yeah, thank you. Also, so do most practitioners utilize the suggested every 3 years for pap smear at this point?
I think so.
Yeah.
That's the, and on the slides, there'll be a society that you can go look at. Now, you get a positive pap smear back, well, that's going to take you a whole different direction. But most of us, it's going to take us to, I'm referring you. But if you're in that situation, those algorithms are readily available, and they get quite complicated. So we're not going to go into that today. I'm not qualified to go into that. And I'll tell you up front when I know what I'm talking about, when I don't, okay?
Thank you.
Cervix cancer. Questions about pre-cancerous disease of the cervix? All right. Cervix cancer. For the last decade, the incidence and mortality have been pretty stable. There's about 12,000 new cervix cancers diagnosed in this country every year. There's about 4,000 deaths every year for the last decade. And that is significantly less than it used to be. And we'll see that on the slides when we go through those. More than 1/3 of women diagnosed with the cervix cancer are going to die from their disease. Unfortunately, from a largely preventable disease. I mean, if we could get people to participate in the vaccination. I want to back up on vaccinate. Go ahead.
Do you know like a ballpark percentage of the people that do participate in the vaccination versus how many are able to?
I think they did comment on the text, but it's pretty low. It's pretty low. We're not doing a good job. Okay, that's why I was thrilled to see some of the commercials, and I don't know if you guys ever saw it. It goes, well, did you know, Dad? That's why I wanted to back up. Initially, the vaccinations were only approved for females. That got changed. And I asked my medical students, well, why did we change it? And they go, well, so we'll protect the females. Yeah, that's certainly part of it. But males get HPV-related morbidity and mortality. A significant percentage of head and neck cancers are HPV-related. Males certainly can get oropharyngeal cancers related to HPV. Some penile cancers are HPV related. Homosexual males certainly at risk for anal cancers related to HPV. So HPV, yeah, we want to get the herd immunized, and that's why we're already, even with a small percentage of people that are getting the vaccinations, it's already having some impact. If we could get people to buy in, we could probably do away with cervix cancer in this country. How do these patients tend to present for cervix cancer? I'm sorry? Spotting after intercourse, very good. Postcoital bleeding, one of the first signs that bring that the patient gets concerned about. Typically, patients are multiparous. Everybody know what I mean by that? They're between 45 and 55 years of age, who delivered their first child at a very early age, usually before 20. The probable first symptom of early cervix cancer is probably a thin, watery, blood-tinged discharge that frequently goes unrecognized by the patient. The classic symptom is intermittent, painless postcoital bleeding. You start hearing that, you better do an exam here. Over time, the bleeding episodes become more frequent, heavier, and of longer duration. Patient might describe periods that seem longer and heavier flow. Eventually, that bleeding will become continuous. Late symptoms or indicators of more advanced disease include pain referred to the flank, pain in shooting down one leg, secondary to involvement of ureters, the pelvic wall, or sciatic nerve roots. Many patients will complain of dysuria, hematuria, maybe some rectal bleeding, some constipation. This is resulting from bladder or rectal invasion. Persistent edema of one or both lower extremities may be related to lymphatic and venous obstruction due to pelvic wall disease. They can result in a hydronephrosis because a lot of the lymph, where the ureters come down, a lot of our pelvic lymph nodes run right by those ureters, and when those lymph nodes get involved, they put a lot of pressure on the ureters or even invade those ureters. That's not a good thing when that happens. We're probably in an advanced stage. So when I was a younger guy, I used to see more cervix cancer, and sometimes we'd bring patients back and we'd weigh them and get their vital signs. Sometimes I knew we had a bad cancer just weighing them in, because I could smell the tumor. I could smell this necrotic dead tissue. It's horrible, and sooner or later you're gonna encounter this in your practice. But and I still see that once in a while, but not here like we used to. Fortunately, I think we're doing a pretty good job of getting people screened and not letting them get that far. But the power of denial is just amazing in these patients. I mean, and I'm not going to spend a lot of time talking about vulvar cancers, but some of these vulvar cancers that I see come in are just, oh my God. When did you decide this was problematic? You got a lesion this big on your vulva. It's just amazing. It truly is. You know, these cervix cancers I just mentioned, you know these patients know something's wrong. You know their families are going, what is that? So why does it take them so long to get seen? I just don't understand that. Power of denial is pretty amazing. Another thing that we see a lot in cervix cancers, or a lot of cancers, are even DVTs can develop, and subsequent PEs, massive bleeding. The gross appearance tends to be exophytic, polypoid mass at the extruding off the cervix or even out of the endocervical canal. But they can present with little visible findings. But when you palpate that cervix, it's rock hard. It feels like you're touching a stone. They can present with more ulcerative appearing lesions. 75 to 80% of cervix cancers are going to be squamous cell carcinomas. Most remaining tumors are going to be adenocarcinomas. Adenocarcinomas of the cervix actually arise from the endocervical mucus-producing gland cells. These tumors tend to be bulky lesions. We don't find them as soon as we do the squamous cells, it seems like. So these bulky lesions, you feel that cervix, and you'll hear it described as a barrel-shaped cervix. I mean, it's just really expanded and just very full. How do we treat cervix cancer? Well, that depends on the stage. First question you ask, what's our stage? Stage 1, meaning cervical involvement only. Then I ask, well, are you a reasonable surgery candidate? Because, just because you've got early stage doesn't mean you're a good surgery candidate. You may have horrible lungs or heart. So if you're stage 1 and you're a reasonable surgery candidate, then we're probably going to offer you surgery. That surgery will entail typically a radical hysterectomy. That doesn't mean we're just getting the uterus. We're going to get some of that parametria, some of that supporting tissue. We're going to get a centimeter of vagina. We're going to get pelvic periaortic nodes. We're going to get tubes or ovaries. And that's somewhat age dependent. For younger females still getting a lot of use out of their ovaries, we're probably going to try to preserve that ovarian function. If you're perimenopausal or postmenopausal, those ovaries aren't doing a whole lot for you, and they certainly can cause some problems. We're probably going to go ahead and snag them while we're there. If you're stage 2 or greater, meaning now we're past cervical involvement, we may have sidewall disease or vaginal disease, then you're going to go to chemoradiation. The chemo we use is not designed to be cytotoxic. I'm not trying to get a cell kill from that chemotherapy. It's very low dose chemo where it's used more as a radiation sensitizer, trying to make that tissue very sensitive to the effects of radiation. And so you get chemo 1 day a week, and 5 days a week you get radiated for a total of 6 weeks. The radiation, for the most part, is external beam using a linear accelerator. Unfortunately, when I do whole pelvic radiation, I'm going to shoot a beam of radiation through that pelvis. When I shoot a beam of radiation through that pelvis, is the cervix the only thing that gets radiated? No, your cervix can take a ton of radiation. The bladder can't, the bowel can't, so I only go so far with external beam, and then I've got to stop. If I continue to go beyond that cutoff point, 100% of ladies are going to have horrible side effects, like rectovaginal fistulas, vesicovaginal fistulas. So I have to stop at a given point. Unfortunately, I'm not anywhere near enough radiation to sterilize that cervix. I have to have a way of boosting the dose way up at point A without significantly radiating surrounding tissue. And the reason I bring this up is, I was a PA for 2 years before I figured out what they were talking about when they talked about brachytherapy. Most of my third-year medical students don't have a clue what brachytherapy is. Brachytherapy is the local application of radiation that tends to spare surrounding tissue. There's a number of ways we can do it. I think we actually have a picture of a brachytherapy device. For advanced cervix cancer, For instance, you got supraclavicular nodes, we're not carrying that. You're probably gonna go to systemic chemotherapy. We're gonna try to buy you time, shrink your disease. We may have to throw in some radiation at different points for things like bleeding control, pain control, pathologic fractures, these kinds of things, but we're not gonna cure that. Questions about cervix cancer? Well, that took about 35 minutes. I don't think we're gonna have 2 hours of talk here, guys. Let's go on to endometrial cancer. Does anybody know what causes most endometrial cancer? Endometriosis? What is endometriosis?
Endometrial tissue outside the
Okay. Some endometriosis has been shown to potentially degenerate, but no, endometriosis is probably not the cause for most endometrial cancer. Are you guys aware there's a type 1 and a type 2 endometrial cancer? Most of our time is going to be spent on type 1. Type 1 is the most common. Too much estrogen. Too much estrogen. Hyperstimulation of the endometrial lines with estrogen. Type 1s tend to be, are typically endometrioid adenocarcinomas. They're typically grade 1. Everybody know what I mean by grade? So they're typically grade 1, well differentiated. When I talk about grade, I'm talking about grade 1, 2, 3, or 4. Grade 1's well differentiated, grade 2 moderately differentiated, grade 3 poorly differentiated, grade 4 undifferentiated. The higher the grade, the uglier the cell looks. The higher the grade, the more aggressive the tumor tends to behave. So again, type 1s tend to be endometrioid adenocarcinomas, grade 1. Type 2s tend to be much more worrisome tumors, and they probably aren't estrogen related. Now they could probably be affected by estrogen, but estrogen probably didn't cause them. Those are going to be things like serous papillary, clear cell, higher grade endometrial cancers. And in grand scheme of things, grade or type 2s tend to be kind of rare. Now we see them, we're a referral center. We get referrals from surrounding states, so we see them. But if you guys are in a primary care setting, I guarantee you you're going to see type 1s. Too much estrogen. When I was a young guy, I used to see patients coming in on unopposed oral estrogen, still having uterus in place. We used to think estrogen was the cure-all, you know, protecting your heart, your brain, and your bones. And back in the late 90s, I think it was, the World Health Organization did a big study, and we kind of figured out that estrogen wasn't doing all the wonderful things we thought it was. In fact, might have been causing some harm. So I don't really see unopposed oral estrogens anymore. If I see a lady on hormone replacement still has uterus in place, it's typically going to be a combination of drugs. It's going to be estrogen and opposed by a progestational agent. So I don't really see unopposed exogenous estrogen anymore. So where are they getting too much estrogen? Anybody know? I'm sorry?
The ovaries?
Well, they certainly get some estrogen from the ovary, but that's probably not where they're getting the excess amount. Probably not. Most of these patients have a certain body habits. Most of them are overweight. Okay, well, what in the world's that got to do with it?
The fat.
I'm sorry?
Oh, sorry.
Shoot.
The adipose tissue can either stores or banks estrogen. Is that?
Very good.
Okay.
It doesn't really store it, but peripheral conversions of androgens into estrogens through the aromatization of those androgens. So there's an enzyme called aromatase when you're got a lot of adipose tissue, you peripherally convert those androgens into estrogens through aromatization. What else might be playing a role? Alcohol, probably not. Could. A lot of overweight patients tend to be polycystic ovary. If I'm polycystic ovary, what do I not do?
Ovulation? No ovulation.
I don't ovulate. If I'm not popping an egg out of that ovary, egg comes out, what do I leave behind? Corpus luteum cyst. What's its function?
Progesterone.
Produces progesterone. So I got all this estrogens bombarding my endometrial lining, and it's causing a proliferation, right? Causing a buildup of proliferative endometrium. Then I ovulate, create a corpus luteum cyst, start producing progesterone. Progesterone causes that endometrial lining to turn into a secretory endometrium, preparing for implantation. Implant an embryo, subsequently start producing beta-HCG, human gonadotropin. If I don't have an implant, the corpus luteum fails, and the hormonal stimulation stops, have a period. So, a lot of times we have anovulatory bleeding patterns can play a role here because I don't interrupt this hyperstimulation of the endometrium. Does that make sense? Prolonged perimenopausal states. The normal menopause, we should see your periods getting less and less amount of flow and further apart. Well, during this time, we may actually be going through an ovulatory bleeding pattern, and sometimes that can increase your risk of too much estrogen. Let's see. Another thing that you guys should be aware of that I always talk to my students about at work is tamoxifen. Tamoxifen is a drug that you'll see used a lot in breast cancer. It is like an estrogen inhibitor. Unfortunately, it acts paradoxically with the endometrium and can stimulate the endometrium and cause endometrial hyperplasia. And so you got a patient with breast cancer that develops, and on tamoxifen develops abnormal bleeding. What you got to be thinking about? You're probably going to have to check that out and make sure she hasn't developed endometrial hyperplasia. So, complex atypical, so endometrial, our precancerous lesion for endometrial is hyperplasia. And I can have varying degrees of hyperplasia. I can have simple hyperplasia. I can have complex hyperplasia. I can have simple atypical hyperplasia, which I don't know that I've ever seen. But the one I see most is complex atypical endometrial hyperplasia. Unfortunately, as high as 40% of those patients really have cancer. You just haven't proven it yet. So we always get slides reviewed here or at the Cancer Institute, and sometimes I'll get complex atypical endometrial hyperplasia in here, and I'll get my pathologist to look at it, and they go, well, you know what, I think that's a grade 1 endometrioid adenocarcinoma. Well, on the flip side, sometimes I get grade 1 endometrioid adenocarcinomas, and I show it to my guys, and they go, well, I can see why they call it that, but I still think that's complex atypical endometrial hyperplasia. The point I'm making is the complex atypical endometrial hyperplasia and grade 1 endometrioid adenocarcinoma, there are just not a lot of difference in the way they look under the microscope. You might show it to 5 different pathologists, you might get 5 different opinions. That's why most patients with complex atypical endometrial hyperplasia are going to wind up getting a hysterectomy. Now, a lot of times I'll get or oftentimes we'll get a patient who just has their heart set on maintaining their fertility. In that case, we would take that patient, we might get an MRI, we might take that patient and do a very aggressive DNC. To the best of our ability, prove there's not a current cancer there, and then we will put her on a progestational agent or put a Mirena IUD in, and then we'll biopsy that lady every 3 months until she changes the paradigm. So what's the chance that most of these patients are going to do what it takes to get pregnant, i.e. lose the weight, and do these types of things? It's pretty low. We don't really see that much. So sooner or later, they probably wind up getting tired of getting biopsy, or the biopsy is going to show that this is progressing, we need to quit playing with it. So most of the time, those patients don't wind up getting hysterectomy, because if you don't change the paradigm, you don't lose the weight, you don't change the lifestyle, then you're not going to change the condition that got you here to start with. So atypical endometrial hyperplasia, 20 to 45% risk of an underlying cancer, and we just haven't identified it yet. So endometrial cancer, especially type 1, is the most common GYN cancer in this country. You go to Mexico, it's probably the most common. Why? Well, just when you're out and about, just look around. It's pretty easy to see why. If I've got a cancer that's related to obesity, what's going on in this country? Mexico the same way. Now you go to Africa, probably still cervix. At one time it was cervix in this country. Nothing more. So again, endometrial cancer is divided into type 1 and a type 2. The most common is type 1. And again, if a lot of you are going to wind up in primary care settings, you're going to see type 1s. Eventually see type 2s as well. Type 2s, a lot of times though, these are very nice men and women. They don't really have a precursor lesion. In other words, type 1s, a lot of times I'll see the path report will say grade 1 endometrioid adenocarcinoma and a background of complex atypical endometrial hyperplasia. You don't see that in type 2s. They're going to be most of the time atrophic endometrium. And they tend to, I think type 2s tend to be more common in like African Americans. These women tend to be thinner, okay? Let's see. So type 2s tend to be like serous papillary, which is a bad actor, high mortality rate, clear cell, and other more aggressive tumors. 58% 5-year survival rate. So we tend to, grade 1s, endometrioid adenocarcinomas, most of those patients are going to do well, especially if they haven't sat out there bleeding for 3 years. And here's something I always tell my third-year medical students, because it's amazing to me. I still get ladies in, to this day. I've been sitting out there bleeding for 2-3 years, postmenopausal. And you go, well, didn't you tell anybody? And they go, yeah, I told my primary care physician. He said, oh, don't worry about it. Let women do that. No, they don't. No, they don't. So first order, you got to get you a new doctor, because you're a doctor. Oh, let's do that. But postmenopausal, if you don't hear anything else, postmenopausal bleeding is cancer until proven otherwise, every time, okay? Postmenopausal bleeding is cancer until proven otherwise. Now, there are some benign things that cause postmenopausal bleeding, like atrophy, trauma, some other things, but pretty rare. So you get a lady come in with postmenopausal, it don't have to just be a little spotting. You've got to check that out. You've got to figure that out. So how do these patients present? Well, most of the time they're going to present with abnormal bleeding. Postmenopausal bleeding, or if they're premenopausal, I'm bleeding all the time. My periods are a lot heavier. I'm having bleeding between periods, so it's abnormal bleeding most of the time. How do we diagnose it? One of the things we'll do is we'll get an ultrasound. We're going to look at the endometrial lining, see how thick that endometrial lining is. Ideally, we want to see that less than 5 millimeters. And then if it's and then typically we do an endometrial biopsy. That used to most of those patients used to go to the OR for a DNC. We've decided that's probably not necessary in most cases, and so in the office now, has anybody seen office endometrial biopsy? In the office, we have this little plastic straw. It kind of looks like a straw. It's called pipelle. And now we can slip that up through the endocervical canal. It's got a little thing we pull back. It creates a vacuum. On the end of that plastic straw is a curette. And you just, curette that as much as you can. It causes a lot of cramping, but it's pretty well tolerated in the office. So we collect that biopsy within, using the pipelle and send that off. Now, if we don't get answers, then we may have to go for a DNC. Most of the time we get the answer we desire. Treatment for endometrial cancer is typically a hysterectomy of some sort. If it's a grade 1, we might just do a simple hysterectomy. If it's grade 2 or higher, but typically we'll do an abdominal or a lot of times we're doing robotic hysterectomies now, and usually with a pelvic para-aortic lymph node dissection. Again, grade 1s tend to do really well. We tend to do well with grade 1s, especially if they haven't sat out there for 2 or 3 years bleeding. Grade or type 2s, we don't do as well with those. There's a significant mortality rate expansion. Okay, guys, so again, the take home from endometrial is there's a type 1 and a type 2 endometrial cancer. Type 1 by far and away is the most common. Too much estrogen. Where's that estrogen coming from? Most of the time these patients are overweight. Might be complicated by polycystic ovary syndrome and ovulatory cycles, so now I don't create a corpus luteum cyst. So now I'm not producing progesterone to try to oppose all that estrogen I'm making peripherally. Type 2s are not estrogen related. Okay? What's our precancerous lesion for endometrial? It is typically hyperplasia with atypia. All right. Questions about that? Well, we take a break here and we'll finish up with ovary. I don't think it's going to take another hour to get talk about ovary.